to set the stage, I'm gonna just also like talk about the iron chelation general role in MDS patients, because obviously there are like, school of thought. Some are believers in role of iron chelation, some are not. We all definitely, I think you built a nice story. Patients are blood transfusion dependent. They don't do as well. Serum ferritin levels correlate with worse outcome. So, but the question, does iron chelation make a difference? And obviously we don't have a randomized clinical trial. So you have to make, some conclusions there, So there had been several retrospective studies that
including at this meeting, you saw that registry data from Europe.
So that suggests that patients that get iron chelation, they do better. And then there are studies that Jamil alluded to, like the EPIC, that showed you can decrease the serum ferritin. Those retrospective studies are obviously criticized by selection bias, that the patients that will get iron chelation will live longer because they were doing better. They could get iron chelation for longer duration. There had been actually some observational prospective studies, like the French that they published a few years ago. They looked at patients that were transfusion dependent and they followed them, and they found out that patients that were on strict iron chelation did better than intermittent, and the intermittent even did better than no iron chelation. This year, I think
better means survival.
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 And interestingly, sometimes even leukemia-free survival. Like in our, when we looked at our experience with oral iron chelators, particularly, that we saw that, and even the serum ferritin levels had been correlated to leukemia-free survival. This year, I think we heard a little bit. It's also like, I think, observational more study, but it's probably prospective as well, because this is through the European network, looking at patterns of use of therapy in Europe, and with the introduction of the oral iron chelators. So we know that historically we used defruxamine, the subcutaneous, which in my experience over 10 years, maybe 2 or 3 patients accepted to have the pumps attached all the week. Then we started having the oral iron chelators, the defracirox, and now the newer formulation. There is another one, the defriperone, that's probably more like myelosuppressive, so we usually don't use it much in MDS. So in this study, first, this treatment is not being offered to many patients with lower risk. So I think it's still maybe 1 out of 4 or 5 patients will get on iron chelation at one point. But what was showed that basically patients did better on oral, especially the defracirox, than the defruxamine. And when you adjust for different factors, it seems that even in this prospective observational study, that there is survival advantage for those. Again, the gold standard for all of us to see a randomized clinical trial going there. The Telesto had been going on for a while, which is a study that looks at that, but it's not easy task to do a randomized clinical trial looking at iron chelation alone without all the other variables. So I think at the end, there is substantial evidence to suggest that, and you either are believer or not believer in the subject.
So you mentioned chelation for the lower risk patients who are transfusion dependent, and there has been some development in recent years with the development of the oral formulations. I think most patients would be on defracirox, and in the United States now we have the availability of the film-coated tablets. So you think that's going to improve the tolerance of the patients?
Right. So as mentioned earlier, I think there are several modalities. Obviously, the oral iron chelators are much more appealing, easier to do, and we have the original defracirox XJ used for those patients, and now we have a newer formulation that's easier to do, probably more compliance for the patients. It doesn't have to be mixed, and patient can take it as tablet. It improves the compliance.
From a gastrointestinal
side. So the data are starting to evolve in other fields that maybe there is less GI toxicity, definitely better compliance. Anecdotally, in some of the patients that we've had, when they shift, they do have less side effects. I think always the use of those medications is a couple of things, as we were discussing, is the benefit and the risk, right? So the benefit needs some time to be seen. So those patients need to be maintained for a year or two at least to see the benefit of iron chelation. So you want to make sure that you are managing the toxicities appropriately. What we see is a couple of things, that those patients are started sometimes inappropriately on high doses. You run into toxicity early on, you stop, or they are started on low doses and then they keep going on low doses that we know that don't do anything on the level of iron chelation. So I think you have this discussion, you assess the patients, you follow them, closely up front, monitoring kidney functions, liver functions every week or other week. And once you get to a point, then you should escalate the dosing. So the new formulas are making that easier. Patients are more compliant with it, less side effects. But again, I think we always should be keeping the toxicity in mind and assessing it closely, especially early on?
I think the use of deferracrox requires significant experience, and that's sometimes challenging. The newer formulation has a different dosing from the dispersible formula. It has about a 30% less dose, so that's something to remember. And the monitoring of organ toxicities is particularly important. But I think also we should also emphasize the expectations. Like, you would like to achieve a net negative ion balance. So in a transfusion-dependent patient, that would be a downward trend in ferritin. But even a stable serum ferritin is not necessarily bad in a transfusion-dependent patient.
And in the setting of patients who are getting blood transfusion, where you expect the serum ferritin will continue to go up, I think it's important that we mention that the approval for the new formulation is based on bioavailability, not studied in patients with MDS. So all the data that we talk about are patients that were treated with deferracrox. The Jadinu was shown to be bioavailable and equivalent, as you mentioned. The dosing is 1/3, but all the studies done in MDS were with deferracrox.
Yeah, but I would just want to emphasize the active agent is the same. So one needs to pay particular attention to the side effects when managing these patients. And a common problem is these therapies are often stopped before we have any benefit, any chance of the patient benefiting from treatment.
With the deferracrox original studies, 50% of patients ended coming off because of side effects, mostly GI and renal. So if you can improve those, then you're going to be able to, with the new formulation, then you're definitely going to be able to improve the compliance and hopefully more effective iron chelation.
I think my preference is to start low and then work my way up gradually, rather than start at full dose and then manage the side effects.
I titrate patients up. I always start low and then go higher.
Because if you look at the data also, that actually there is difference in meaningful iron chelation. So like if you look at the serum ferritin reduction, it's usually with the higher doses. So you need to go up with the dose at one point to have meaningful chelation. But to your point, I think I totally agree. Like, start low, make sure the toxicities are, managed.
Give some time for them to,
and then escalate. Don't keep the dose at the low level. So.
And this has to be a medication that the patient's tolerant to take over time. You don't want to start at a level where they absolutely are not going to want to be on this medication ever again. You want to be able to adjust it so that they're willing to take it over time.
Especially when you're treating a problem that's not symptomatic.
That's right. So it's like treating hypertension, right? That people don't really realize that they have high blood pressure. It's the same sort of situation.